Welcome, everyone. Thank you so much for joining us tonight. We're going to wait a few seconds to get started because people are still rolling in here. I do just a few housekeeping things. You'll notice that as you log in, your mic and video are muted. They will stay that way, but we encourage you to ask questions in the Q&A and then comments in the chat. In the meantime, hop over to the chat and give us a greeting and let us know where you're tuning in from. For example, I am in Seattle and we have some folks who are going to be speaking who are from Iowa, Minnesota, and Florida and Michigan, so all over the nation. So yes, let us know where you're tuning in from so we can see what cities and states are represented tonight. All right, so we'll just give it a few more seconds and then we'll get started. Okay. All right, welcome. My name is Sakpal Tan. I am the program director for the National Pancreas Foundation. One of our programs that I oversee is our diabetes initiative, because with pancreas disease, diabetes goes hand in hand for many of you. Today's webinar is titled Type 3C Diabetes, Therapies for Diabetes Related to Pancreatitis. If you missed our first webinar, I would advise you to go, not right now, but go afterwards, go to our YouTube channel. I'll also put it in the email that I'm going to send out to, later this week. And then I can also put in the chat as well, but it's basically, it was learning about type 3C diabetes, differences between 1 and 2, and then also diabetes screening and risks. Just a few notes, this webinar is being recorded and will be sent out to all registrants by the end of the week tonight. We are joined by some amazing speakers. I'm gonna hand over the mic to Dr. Melina Bellin. She is a professor of Pediatric-Endocrinology at the University of Minnesota and a member of the NPF Board of Directors. We're so lucky to have her involved in so many of our programs. And she will provide a framework for the discussion and introduction to our speakers as well. Dr. Bellin, take it away.
All right, thank you, Sakpal, and welcome everyone who's tuning in tonight and those who may be tuning in later to the recorded version of this. We're very pleased to have, as Sakpal noted, our second webinar in this series by NPF. One of our initiatives has been to try to increase education for both patients and providers in the type of diabetes that is specific to pancreatitis, why it occurs in its management. The framework for these sessions is that we invite a couple of medical experts in the field, Dr. Pratley and Dr. Larson Ode, joining us tonight. And then we also invite a patient. In this case tonight, Derrick Winke is with us to tell his story. I'm joined by a co-moderator, Dr. Graciela Paravisma, and she is from the University of Iowa. She actually works alongside Dr. Larson Ode, and she is a pediatric endocrinologist. So we love our pediatricians involved in the diabetes and pancreatitis world, and she has an interest in this topic of pancreatitis related to diabetes. So we will trade turns here, introducing our speakers and helping with the Q&A. I think as Sakpal noted, there's a Q&A box here, and so we ask you as our presenters are speaking or afterwards to throw any questions you have in that box for discussion later. So with that, I think I'll turn it over to our first speaker and welcome here Dr. Rich Pratley, who I've really had the pleasure of getting to know and working with over the past few years in diabetes related to acute pancreatitis in particular. He is from AdventHealth, where he is serves as the Samuel E. Crockett Chair in Diabetes Research. He's a senior investigator and diabetes program lead at AdventHealth Translational Research Institute, and the medical director at AdventHealth Diabetes Institute, which is based in Orlando, Florida, for those of you who may not know. And he is an internationally recognized expert in diabetes, has a number of publications in this field, and as I noted, has expertise specifically in this diabetes that occurs related to pancreatitis. So he will be speaking on medication therapies for pancreatitis-related diabetes. Rich, I will turn it over to you.
Thank you, Melina. And let me tell you what a pleasure it is to be here tonight to speak to you about diabetes. Thank you for the invitation. I think this is a really important initiative. I'm going to go ahead and share my slides as soon as Sakpal allows me to do that. So if you could make me the host, I will. There we go. So just a little bit of background. I am from AdventHealth in Orlando, Florida. Our hospital system has about 55 hospitals throughout the country. We have 30 here in Florida, and our main campus here in Orlando has a 2,900 bed hospital. So we're a reasonably big hospital system, fully integrated. And on the left-hand side is our Diabetes Institute. On the right-hand side of the picture is our Clinical Research Institute, where I see our patients for diabetes studies. These are my disclosures. I do work as a consultant for a number of companies that develop drugs for the treatment of diabetes. All honoraria are directed towards a nonprofit that supports education and research. And my other disclosure is that I also serve on the American Diabetes Association Professional Practice Committee and the Precision Medicine Committee. So I know that many of you attended the prior webinar, which was about 6 months or so. And so you heard a little bit about the different types of diabetes. But I thought for those of you who hadn't, it would be worth just a little bit of a review. When we're talking about diabetes, of course, this is a disease of high blood sugars. But we do have specific definitions based upon a fasting glucose on the left-hand side here, above 126 milligrams per deciliter. During a glucose tolerance test, glucose above 200 is diagnostic of diabetes. And more oftenly in clinic, what we're using is the hemoglobin A1C or A1C. This is, if you will, a measure of the average glucose over approximately 3 months before the blood test is taken. It's in different numbers than the fasting or 2-hour glucose levels, but it correlates very highly with the average glucose over that period of time. So it's a very useful measure of somebody's overall diabetes control. So we care about diabetes, of course, because if your blood sugar is real high, you can run into serious medical complications. But mostly we care because of the long-term complications of diabetes. So high blood sugars over time can lead to a number of chronic complications. These include things like diabetic retinopathy or eye disease, diabetic nephropathy or kidney disease, neuropathy, which is numbness, tingling, pain, burning in the lower extremities most often, and then things like cardiovascular disease, heart attacks, strokes, as well as a number of other complications. But these are really the factors that drive the morbidity and the costs associated with diabetes. And it turns out these comorbidities are not all that uncommon. For example, up to 40% of patients with type 2 diabetes will develop chronic kidney disease. That doesn't mean they're on dialysis, but they'll have impairments in kidney function. 2- to 4-fold increased risk of cardiovascular disease in patients with type 2 diabetes, and a 2- to 5-fold increased risk of heart failure in patients with type 2 diabetes. Now, chronic kidney disease, cardiovascular disease, and heart failure are also increased in the other type of diabetes, type 1 diabetes. So these metrics are generally true in patients who have diabetes over a long period of time. We know that glycemic management can reduce the risk of diabetes-related complications. This is data from an old study called the UK Prospective Diabetes Study. This is in type 2 diabetes. But the important point is that improved glucose control is associated with a number of benefits, including reduced risk of stroke, heart attack, peripheral amputations, microvascular disease, and mortality. So a very important finding, and this is really the basis for our goals for treatment. These are the American Diabetes Association recommended glycemic goals. And it really starts with an A1C of less than 7% for most non-pregnant adults. And this is based upon the strong evidence that we have from the UK Prospective Diabetes Study, as well as other studies. For certain patients, a goal even lower may be achievable and preferable, but we can also flex that in patients who have a limited life expectancy or very complicated conditions, and where the glycemic improvement wouldn't be expected to improve overall outcomes. So this is the current status of diabetes. in the United States. We have in excess of 37 million people with diabetes, about 11% of the US population. Most of them are diagnosed, but about 8 million aren't undiagnosed. And this shows you a very important point, which is people can have high blood sugars without having any symptoms at all. There also is this class of pre-diabetes. These are people who have higher blood sugars, but not yet in a diabetic threshold. And there are about 96 million people in the US with pre-diabetes, or almost 40% of the population. Now, when we think about this many patients with diabetes, and the answer is, of course they're not. This is not a single disease. So just to remind you, we're talking about multiple diseases that have hyperglycemia as sort of the manifestation. There's type 1 diabetes, which is generally an autoimmune disease in which there's destruction of the cells, the beta cells that secrete insulin, which is important for controlling blood sugars. Type 2 diabetes is an entirely different disease. It's characterized by beta cell dysfunction. So the insulin secretion is not normal, but the insulin also doesn't work normally in the body. We call this insulin resistance. There's gestational diabetes that happens during pregnancy that looks very much like type 2 diabetes. And there's these other specific types of diabetes, some genetic causes of beta cell dysfunction, the endocrine pancreatic diseases that we're going to talk about this evening, and then other rare forms of diabetes. But what I want to put out to you is that the exocrine pancreatic diseases, as you know, are not that uncommon. They may be almost as common as type 1 diabetes, which constitutes about 5% or so of all cases of diabetes. Regardless of the cause of diabetes, we know that if you look at somebody with diabetes, we can measure multiple metabolic defects that contribute to hyperglycemia to one degree or another. So things like impaired insulin secretion from the beta cells, or insulin resistance in the skeletal muscles, or increased glucose production in the liver, or indeed increased glucose reabsorption from the kidneys. So there are multiple organs involved that contribute to hyperglycemia in diabetes. I'm part of a precision medicine group at the American Diabetes Association. This was an earlier report from this group published 2 or 3 years ago. And what it really laid out is a strategy to get better about diagnosing diabetes, about classifying people correctly so that the correct treatments could be applied. And you don't have to go into the details of the slide, but just understand that the whole purpose of precision diagnostics is to make a correct diagnosis so we can use the right therapies. This is one of the areas where pancreatic diabetes is lagging behind. We oftentimes don't make that diagnosis. But it has been studied in patients with type 2 diabetes. This is a great study from Sweden where they took patients with new onset diabetes and they looked using some very simple clinical variables if they could subclassify them into different groups. And in fact, they could. So on the left-hand side are those same metabolic abnormalities that I had on the previous slide. And what they found is that there were basically 5 different types of diabetes. One which was typically associated with type 1 diabetes, characterized by autoimmunity. But there was another group that had insulin deficiency that was called type 2 diabetes, but responded very much like those people with type 1 diabetes. And then there were other groups with insulin resistance or obesity, and even a mild age-related group. All of these groups had sort of different trajectories and responded differently to medications. So it seems like these groups make some sense physiologically, and these groups have been replicated in other populations. So let's talk specifically about these other specific types of diabetes, including the exocrine pancreatic diseases. This review in, I think, gastroenterology, Lancet Gastroenterology, is a great summary of pancreatogenic diabetes, or diabetes secondary to chronic pancreatitis and pancreatic cancer. And it went into greater detail than the American Diabetes Association does about the causes of diabetes in patients that have pancreatic abnormalities. And there's a whole plethora of pancreatic abnormalities, including common things like pancreatitis, acute pancreatitis, but also things like cystic fibrosis, hemochromatosis, which is another genetic condition, pancreatic cancer, and pancreatectomy for surgical purposes. All of these types of pancreatic diabetes are different. They're different in the degree of insulin secretory defect, as well as probably the pathogenesis, or the causes of that type of diabetes. So just like with type 2 diabetes, when we talk about pancreatogenic diabetes, we're really talking about a mixed group of conditions that are brought together by the hyperglycemia, the high blood sugars, but also have very different causes. I mentioned that pancreatogenic diabetes is relatively common. It's estimated there are about 300,000 cases of acute pancreatitis a year in the US, and these people are at increased risk. If you look at hospitalized patients, about 9% will have pancreatic diabetes. The majority, of course, will have type 2 diabetes, but a substantial fraction have type 1 diabetes. When it comes to how we think about type 3C diabetes, it is perhaps an overlap. So some elements perhaps of type 1 diabetes, especially insulin secretory defect, but also elements of type 2 diabetes, because it turns out some of the risk factors for pancreatogenic diabetes are the same as they are for type 2 diabetes. Now, people who've had acute pancreatitis have about a 20% risk of developing diabetes within the first 5 years, and this increases to 40% after 5 years. But what's important is individuals with acute pancreatitis go on to require insulin therapy more frequently than people who have typical type 2 diabetes. So this is one thing we think puts pancreatogenic diabetes apart. Predictors of diabetes after acute pancreatitis, of course, include age, things like metabolic syndrome or obesity, and then things like glycemic variability. So some of the same things that predict risk in the general population. In terms of chronic pancreatitis, about a third of people with chronic pancreatitis already have diabetes, and it's estimated that the lifetime risk is as high as 75%. So 3 out of 4 people with chronic pancreatitis may develop diabetes. The risk factors here also depend upon the duration of pancreatitis, the etiology of pancreatitis, and it also depends upon things like obesity and family history of diabetes, which we know increase risk in the general population. So let's turn to treatments now. This is kind of a historic year because it's really the 100th anniversary of a miracle drug. On the left-hand panel here is patient JL in December of 1922. This poor, emaciated young boy has type 1 diabetes. Here is the same patient about 2 months later. You can see that he's put on about 14 pounds, looks like a normal boy. And the miracle drug, of course, is insulin, discovered in 1921. First treatment started in 1922. So we're really at the historic anniversary of this. On the left-hand panel, Banting and Best. Banting was a surgeon practicing in around Toronto. He had this idea that the islets contained something that would help control glucose. So he begged somebody at the University of Toronto to help them study with it. They didn't have the time to do that, but they said, come use our lab over the summer. And they did some experiments in dog. This is Marjorie, the little dog there. She was the dog that was first successfully treated with insulin, which they extracted in the laboratory on the right-hand side from the pancreas. The first patient to receive insulin was actually Leonard Thompson. This is his medical record from Toronto General Hospital. You can see, compared to our medical records of today, it's pretty spare. And note that he was hospitalized in December of 21 and discharged in about May of 22. Now, upon his discharge, the doctors went to the Toronto Daily Star, as good doctors do, and said, look, we're on track for a diabetes cure. They got their pictures on the front page of the Toronto Star. And a year later, the Nobel Prize was awarded for the discovery of insulin to Banting and John McLeod, who was one of the professors at Toronto. So since then, there have been continued developments for insulin. We have new insulins that are short-acting, new insulins that are long-acting, and we continue to innovate around insulin. So this is important for patients with type 1 diabetes, but it's also relevant for patients with pancreatogenic diabetes and type 2 diabetes. And in the type 2 diabetes world, there have been an extraordinary explosion of new treatments, especially within the last 20 years or so. We now have over 12 classes of medications for treating type 2 diabetes, some of which are relevant for pancreatogenic diabetes. How do we make sense of all of these medications? And the answer is the American Diabetes Association has some guidelines for the treatment of diabetes. And we recommend different therapies for different types of people. If you have heart disease, or certain therapies. If you want to minimize hypoglycemia, there's certain therapies. If obesity is a problem, certain therapies, and so on and so forth. So we do have some structure around this. But really what we're trying to do is match the pathophysiology, the abnormalities that we see, to the class of medication. So when people have beta cell defects and don't secrete enough insulin, we give them insulin, or other medications like the sulfonylureas. So this is just an example of how knowing the pathophysiology has led to the development of different treatments for diabetes. And I'll talk a little bit about some of these other treatments. So why does this matter? Why don't we treat all patients the same? Going back to this study from Sweden, it turns out these different diabetes clusters responded very differently. The people with autoimmune diabetes, and kind of the dark blue on top there on the left-hand panel, required insulin therapy much earlier, as you might expect. But so did the patients who had this insulin-deficient diabetes. And in contrast, other groups did better on metformin or other oral anti-diabetic drugs. So it makes a difference what kind of diabetes you have, because this can determine what kind of treatment is best for you. So we came up with a schema, published this in Endocrine Clinics last year, trying to pair up the different types of diabetes with the appropriate medications that were available. Now, most patients with pancreatogenic diabetes don't really start on insulin. Oftentimes they're started on the usual oral agents for the treatment of diabetes. It depends a little bit upon how severe their diabetes is, but we have several classes of medications that we've used for literally decades. Drugs like metformin, for example. Metformin is a very commonly used drug. About 46% or so of type 2 diabetes patients are on metformin. It has a number of benefits. No risk for low blood sugars. It doesn't cause weight gain. It may have some cardiovascular benefits. It has some disadvantages too. It has an increased risk for GI upset. And in rare cases can cause a serious condition called lactic acidosis. The other major class of medications is the sulfonylureas, or SUs. A lot of experience with it. This was actually the second class of medicine after insulin was developed for treating diabetes. But the downsides of sulfonylureas include an increased risk for low blood sugars, some weight gain, and they just don't work all that well for a long period. We've had a class of medicines called the TZDs, which are insulin sensitizers. So they work in an entirely different way than those first two classes of medications. They have as advantages, they don't cause hypoglycemia, and they seem to be very durable. They also have some other benefits, such as decreasing risk for cardiovascular disease, but they're associated with things like weight gain, a risk for heart failure, some increased risk for bone fractures. So with all of the medications, there are advantages, but there are also disadvantages. So when we're weighing treatment options, we always try to balance risk versus benefit. Metformin is typically the preferred drug for the treatment of type 2 diabetes, and I would say the same often applies for pancreatogenic diabetes. We use it because it works well. There's a low risk for hypoglycemia. It doesn't cause weight gain, a long record of safety, literally decades, and then it's very cost effective. In fact, metformin is cheaper than dirt. Now, you might think this is hyperbole, but I actually did some field research on this very topic. In our grocery store, Publix, you can get metformin for free. And you'll notice that the sign is right in the cookie aisle, right under the Chips Ahoy. I think this is strategic placement, as they call it in marketing. On the very same trip, my wife and I went to Home Depot. We had to get some potting soil. Potting soil goes for $4.97 for a 1 cubic foot bag. So this proves, in fact, that metformin is cheaper than dirt. Now, another major class of drugs for the treatment of type 2 diabetes is the incretin therapies. These leverage a natural hormone system, the GLP-1, GIP incretin hormones that are produced in the gut that help to control glucose levels. We have two different flavors of these drugs. These are either GLP-1 analogs, and these are typically injectable proteins. There actually are most efficacious class of glucose-lowering drugs for the treatment of type 2 diabetes. Some of these are just spectacular. They're also associated with some certain other benefits, including things like weight loss and a decreased risk for cardiovascular, as well as renal disease. So lots to love about the GLP-1 receptor class. The other major way to leverage this incretin system is to block enzyme called DPP-4, which degrades the endogenous GLP-1 and GIP. And these are pills. There are a number of these available. They're very well tolerated. They do work, but they don't have some of the same benefits in terms of cardiovascular benefits that the GLP-1 receptor agonists have. Now, the downside of this class of medications is that both the DPP-4 inhibitors and the GLP-1 receptor agonists carry warnings about an increased risk of pancreatitis. So these are not necessarily a class of medications that we turn to initially for the treatment of people with pancreatogenic diabetes. Now, both the DPP-4 inhibitors and the GLP-1 receptor agonists have had large long-term studies with tens of thousands of patients. In those studies, there have been a few cases of pancreatitis, and it turns out for the DPP-4 inhibitors, there is indeed an increased risk of pancreatitis, but this doesn't seem to play out for the GLP-1 receptor agonists. Nevertheless, because GLP-1 receptor agonists can be associated with gallstone disease, we don't recommend them for people that have had recent pancreatitis. The other major newer class of drugs that we're using nowadays are called the SGLT2 inhibitors. These work specifically on the kidney, and what they do is prevent the reabsorption of glucose that's filtered from the blood. So you end up urinating out glucose. And this can be 70 to 80 grams of glucose a day. This decreases glucose levels. And it's also associated with a little bit of weight loss, as you can imagine. There's a very low risk for hypoglycemia with these medications, and they're associated with a reduction in blood pressure. Now, these drugs have also been studied in long-term outcome studies, and it's been shown that this class of medications decreases the risk for chronic kidney disease or diabetic kidney disease, DKD. It decreases the risk for coronary artery disease, and they decrease the risk for heart failure. So there's a whole lot to love about this class of medications. But they're also associated with certain risks. Some risk of dehydration. There's an increased risk of genital mycotic infections, so yeast infections. And that does happen in between 5 and 10% of patients on these medications. A slight increased risk of urinary tract infections. But most importantly, there's a risk of diabetic ketoacidosis. This is a very serious complication of diabetes. People can get sick, and they can even die from this condition. It typically is seen in patients with type 1 diabetes, but it can be seen in patients with type 2 diabetes who are treated with this class of medications. So we have to be wary of DKA in both patients with type 2 diabetes, as well as the small number of patients with type 1 diabetes that have been treated with this class of medications. So what do we know about diabetes and pancreatic exocrine diseases? Well, I told you that they're associated with an increased need for insulin therapy. So in the blue is a typical group of patients with type 2 diabetes. Orange are people with acute pancreatitis, and green people with chronic pancreatitis. So after about 5 years, almost half the people with chronic pancreatitis require insulin, and about 20% of patients with acute pancreatitis require insulin for glycemic control. So this suggests that there's something different about this type of diabetes compared to type 2 diabetes. And we really should think about replacing insulin in this type of patients. So how do we go about doing that? Well, first, let's turn back to the physiology. This is what happens when people eat. There's a prompt increase in insulin secretion following any meal. You can see at 8 o'clock, at noon, and again at dinner time, there's increase by about tenfold in the insulin levels, and it comes down rapidly following the meal. But even overnight, there's insulin that's being secreted that helps to control the blood sugar. We call this the basal insulin secretion. So in people who don't secrete enough insulin, what can we do? And the answer is we can help to mimic this natural effect with the different types of insulin we have. So we have insulins that are very long-acting, insulins like U300 glargine and degludec. And these are essentially flat insulins that last for more than 24 hours. But on the other end of the spectrum, we have very rapid-acting insulins, things like aspart, glulisine, and lispro. And these can be used to mimic the normal rise in insulin that we see following a meal. Now, they don't perfectly mimic that because they're not as fast, but they go a long way to helping control glucose responses to a meal in patients who don't secrete enough insulin. So we'd like to have both basal insulin and this prandial or mealtime insulin on board to mimic the normal pattern. About half of the insulin we need is in the form of basal insulin, and this keeps the plasma glucose stable even in the absence of food. Basal insulins are very easy to administer. It's typically one injection a day. No mixing is required. We usually use pens. It's very quick to do, and it works well. And they have a low risk of hypoglycemia or low blood sugars. We have several of these available. They differ a little bit in their characteristics and how long they act. And for the most part, we're using these ultra-long-acting analogs like insulin glargine U300 and insulin degludec. On the other end of the spectrum, the rapid-acting insulins, we have several of these available, and they keep making adjustments in order to try to make these even faster acting so that we can better mimic normal insulin secretion. What I want you to know, though, is that you see there in kind of the light gray, the profile for regular human insulin. This is regular human insulin when it's injected into the skin, just like all these other insulins, which is not the way it's normally secreted from the pancreas. So there's a big difference when we're injecting insulin compared to when the body actually makes it. And these drugs, because of their faster acting mode of action, are used typically before meals to help reduce that postprandial blood sugar response, and can be given up to 3 times a day. Finally, there's an inhaled version of insulin, inhaled human insulin, and this has been on the market for some years, and it's very fast acting. It's a great option for many patients. But we're not done yet. We have once weekly basal insulins in development. There are 2 that are in late stage now that are likely going to be approved within the next year or so. And you might think giving a big dose of insulin once a week might be dangerous. Turns out it works great. It works even better than some of our standard insulins with no increased risk of low blood sugar reactions. We're even developing some wild insulins that are responsive to glucose. So they work when glucose is high, don't work when glucose is low. This is the ultimate in what we need to help prevent hypoglycemia. So summarizing the treatment of diabetes in pancreatic exocrine diseases, we really need a better understanding of the etiology and pathogenesis of diabetes so that we can guide better treatment. We have to recognize that this is a very heterogeneous group of people, and we need to understand what type of pathophysiology people have. In general, patients with pancreatic exocrine diseases are treated more often with insulin than are people with type 2 diabetes at an earlier stage. As I mentioned, we have concerns about the incretin hormone therapies, GLP-1 receptor agonists, and the DPP-4 inhibitors. But we do need, we need to keep that in mind when we're selecting therapies. And we need more studies, honestly, because sometimes things that we perceive might be a risk might actually be quite beneficial. The SGLT2 inhibitors, very little data on these in patients with pancreatic diabetes. There have been some case reports of pancreatitis, but on the other hand, people with diabetes itself can develop a pancreatitis in the absence of any medications. So it's really not clear that this class of medicines is associated with pancreatitis. In fact, the long-term studies with this class of medications has indicated there's no increased risk of pancreatitis, and this is not part of their warning. So I'm going to close at this point. I probably have said too much, but I'm going to invite everybody to connect with me either by email or through Twitter or on LinkedIn. And thank you for your attention.
Thank you very much, Dr. Pratley, for that wonderful and informative talk. We're going to take all of the questions at the end. So hold tight, put your questions for Dr. Pratley in the Q&A, and I'll turn it over to my co-moderator to introduce the next speaker.
All right. The next speaker is Dr. Larson Ode. She is a pediatric endocrinologist and a clinical professor of the pediatrics at the University of Iowa, Stead Family Children's Hospital. She's national recognized expert in diabetes associated with disease of the exocrine pancreas, like type 3 diabetes mellitus, and also cystic fibrosis-related diabetes and diabetes associated with pancreatitis. She's a member of the NIH-funded consortium for the study of the chronic pancreatitis, diabetes, and pancreatic cancer, a national study group focused on pancreatitis and its complications. And she's also my mentor. So I will be leading to Dr. Larson Ode, which she's going to speak about diabetes technologies, pumps, CGMs, and their use in pancreatitis-related diabetes.
I think we just need the host function turned over to you, right, Katie?
Yes, I don't have it yet.
Okay.
Dr. Pratley,
Rich, can you pass on the host function?
Okay, he did it. Okay, I'm gonna grab my PowerPoint. Okay. All right, let me. So I need to make this so I can actually start this thing. Okay, come back here. Okay. All right, there we go. All right. So I'm very happy to talk to you today. And that was Dr. Pratley's wonderful talk is a great introduction to my talk. I'm actually really just gonna talk about technology. So this slide here, I just love, it's from the Awkward Yeti. I think it's fun to start with something cute. So my disclosures, I am a pediatrician. I do not really take care of adults very much. I have research funding as above, and I do, my only major thing that I have is I have gotten money for Vertex Pharmaceuticals, but that's not relevant to this particular talk. So so when we talk about technology for treatment of diabetes, there's really two things that we're trying to use technology for. The first is to measure blood sugar or glucose levels, and the second is to give insulin. So obviously there's lots of other treatments for diabetes besides insulin, which we just had a wonderful talk about. But when we're talking about technology as far as treatment, we're really just talking about these two things. Importantly, there really isn't anything that is specifically FDA approved for type 3 CGM. And there actually isn't a lot of study of any particular therapies in this type of diabetes. And so Dr. Bellin, of course, is one of the world's greatest experts in this area. And so she actually has done a trial of closed loop insulin infusion, which is a type of technology that was done in 2015. I will talk a little bit more about what that is later. And there is a trial of continuous glucose monitoring in type 3 that is ongoing, but there's actually not a lot out there specific to type 3 CGM currently. So, now my slides aren't advancing. There we go. Okay, so let's start with talking about measuring blood sugar. So there are a couple different problems when you're trying to measure blood sugar. The first one is getting to the blood or whatever substance you want to measure the glucose from. And then, of course, the accuracy of that measurement, and then how often you can get that information when you want it. So the most common way that we measure sugar at home is by finger poke. And that actually is not the same as if we draw your blood and measure your glucose. It's actually capillary glucose, which is just slightly different. This picture is a picture of different generations of these home glucose meters, which were first available in the late 80s. And things that are good and bad about these is that home meters can vary a lot from your what we would typically call your real glucose, which is your venous glucose, which is a glucose measured from your actual blood draw in a clinical lab. And they usually vary about 12 to 20% from that value. So the number they're reading out can be up to 20% different from what we would get from a lab. running your blood glucose level, your blood sugar level. Although there are newer ones coming out that are quite a bit more accurate. And so this is improving, but if you get a random meter from the wall in the pharmacy, they can be up to this far from the true blood sugar measurement. The good thing about these things is they take a very tiny amount of blood, and it's very easy to do this at home. The greatest number of times you can really practically check your blood sugar using one of these devices is about 8 to 10 times a day, which is a lot. And for most people, that is more than they really ever want to do. And so there is kind of a limit of how many blood sugars you can get from this method. Although this is a great method, and these are also pretty reasonably priced devices. So you can also measure your sugar levels, not in your blood, but in the fluid that flows around your cells, which is called your interstitial fluid. So sugar, like when we talk about diabetes, we have a tendency to talk about sugar as if it's bad, but sugar is your primary fuel for all of your cells. So every part of your body needs to have access to sugar pretty much all the time to be healthy. And not all of your cells are in direct contact with a blood vessel. So how nutrition, which is mostly sugar, gets to those cells and the waste get away from those cells is by fluid that comes out of the blood vessels and then flows around the cells. And that's called interstitial fluid. And the neat thing is that in the context of advancing technology, we have determined ways to measure what the sugar level is in that fluid. And so to measure that, you don't have to actually poke somebody to take blood out to measure it. You can actually put in a tiny little device under the skin that can measure that in a nearly continuous fashion. So the technology we use to do this are called continuous glucose monitors. They are very accurate. They tend to vary about 7% from a glucose that's measured from a blood draw. And they give you lots and lots and lots of measurements. They measure between every 5 minutes, some measure every 1 minute, depends on what the device is, but they give you lots and lots and lots of numbers. They do that glucose in that fluid around your cells gets there a little bit later than the glucose from your blood. And so when you measure this number, it does tend to happen later in time. It's not really a problem when you're running high, but if you're low, it takes a while for the number measured in this fluid to come up to normal. The amount of glucose in your blood comes up much faster than the amount of glucose that's in your interstitial fluid. So when you're using these to check blood sugar, that is something you have to keep in mind, because if people wait until this number comes up to the goal, sometimes you overtreat a low. So let's talk in a little bit more detail about these continuous glucose monitors that measure that interstitial glucose. And these are called variously continuous glucose monitors, CGMs, or sensors, depending on who you're talking to and how they like to call it. So I'm going to go through the devices that I typically use in my practice, and I'm going to go in order of my least favorite to my most favorite, and I'm going to do this with all of the technology. So really the first practically available sensor came from Medtronic, and their current sensor is called the Enlight sensor. And like all sensors, the actual thing that measures your blood sugar is a tiny little platinum filament. And they're only a little bit wider than a hair, depending on the company. They vary in length. They vary from about half an inch to about an inch long, depending on the company. And that is inserted under the skin with a little device that goes ka-tunk and inserts that little wire under your skin. And then there's a device that sends the information from that wire to whatever technology you're using to utilize your blood sugar or look at your blood sugar, or you transfer it to other systems. For the Medtronic system, the sensor, which is that filament, so that's the thing that actually measures your interstitial glucose, that is this kind of gray clear part. And then this whiter part here is the part that is called the receiver, and that's the part that sends the information to the rest of the system. The current version of the Enlight requires calibration, although that is going to change quickly and soonly. And then, so that means you still have to poke your finger and enter that number into the system a couple of times a day to make sure that the system the system utilizes that number to calibrate the reading. And then the nice thing about this sensor is it interfaces with the Medtronic pumps, which is really good. So the next sensor that I use with my patients when I'm taking care of them is the Freestyle brand sensors, and they also measure the blood sugar with platinum subcutaneous filament. The Freestyle meters actually come in two different types. They come in what's called a flash meter and also a continuous meter. And so the flash meter, and this is the only, in the flash meter, instead of, it's measuring the glucose levels all the time, but it doesn't give you the information unless you ask for it. So this kind of black thing with the number on it, and the reason this number is funny is that's European blood sugar values instead of American version. And so you would wave this device over the button to get your blood sugar number. And so it's not reading out all the time. The continuous monitors read out your blood sugar all the time and display it on another device. And so you're seeing that information all the time. And some people actually appreciate only getting the number when they ask for it, because they can find the constant influx of their blood sugar number to be somewhat overwhelming and stressful. So some people actually really like the flash version where you only see the number, even though it's recording all the time, and you can download it if you want it. It's not showing up all the time where you're looking at it. And so the thing about the Freestyle meter is that it is all one device. So there aren't the two parts like there were on the other one where this part with the filament is separate from the part that sends the data. And that's kind of nice because with the separate ones, you have to save the transmitter. And I definitely have had patients accidentally throw those away, and it's a problem. And the nice thing for this one is it's all one piece. It's also pretty small. So you can see in this picture, it's attached to this person's arm, which this is how you wear it. The white part is the device. And then this part around here, that's the tape that holds it on. And there's two models of the Freestyle that are currently available. And the right-hand one is the older one that typically is a flash, and the left-hand one is the newer one. Currently, the Freestyle does not communicate with any of the available pumps, but that is, we've been told, coming. So hopefully this will soon talk to some of the other devices. Right now, this can only be used for blood sugar monitoring. This is also the least expensive device. This is the only one that I've had that's cheap enough that my patients have been able to pay for it if their insurance does not cover it. The other devices cost so much that most people, excuse me, cannot afford them if they're not covered by insurance. But this one is within the range that some people can afford to pay for it, even if their insurance doesn't cover. This is a very nice little device. Excuse me. I'm off my allergy meds, so it's a problem. I apologize for the sniffling and coughing. So the Dexcom is my favorite sensor. It measures the glucose with the same filament that the other devices use. Dexcom only offers continuous monitoring. There's no flash available for Dexcom. This is an extremely accurate sensor. It is more accurate than the other two sensors. And is one of the reasons I like it. There's currently two models available. The G6, or the older model, is the top picture. And similarly to the Medtronic device, there's a separate part that holds the filament and then a separate part that transmits the data. And so this one, kind of the cleary purpley part, is the part that actually has the sensor hooked to it, the filament, and then that gray part is the part that transmits. And so you pitch this part. All of these things, the actual filament lasts 7 to 10 days. And so they, excuse me. And so you have to throw away the filament every 7 days, but you got to hang on to this gray thing. And then that's the G6. And this picture is slightly deceptive because the G6 actually has a huge piece of tape to hold it on, which they don't have in this picture because they don't want you to know how big the piece of tape is. And then the G6 just sends the number to you can get a receiver, but most people have it go straight to your phone. So there's a little app that shows your number. And then you can open it up and see the pattern, which is pretty nice. And it can also send to your watch. And then the G7 is the newer one from Dexcom, and it's smaller. It's all one piece like the Freestyle, and you can see the tape is much smaller. Interestingly, the G6 interfaces with multiple different pumps. The G7 doesn't currently, but will soon. I have had a few patients who have been on the G7 and actually switched back to the G6 because even though this is really nice and it's small, it fell off more because there was less tape. So different people have different preferences depending on what they're utilizing, but these are really good sensors. And the Dexcom is my preference if I can get it covered by insurance for people. So the first thing we do is we measure the blood sugar. And so we know what not really the blood sugar, but we measure the sugar level. So we know whether or not we need to treat it. And then the second thing we're doing with technology is giving people insulin. We just heard a really nice talk discussing about lots of other ways to treat diabetes, but with technology, we're generally just giving insulin. So of course, there's problems with giving insulin. The first one is getting it in your body, actually. So insulin is a protein hormone and it cannot be taken orally. It has to be injected or infused. And as was previously discussed, it's really important to get the right amount of insulin. It has to have the correct duration for what you're trying to do. And then it must be absolutely accurate. Your insulin dose must match your blood sugar, your activity level, and your carbohydrate intake. And if you have too much insulin, you're going to have a low blood sugar. And if you have too little insulin, you're going to have a high blood sugar. And this picture is very similar to actually one we just saw, but it's just showing the normal glucose pattern in red in a day. And then it has the insulin pattern overlaying it, which is what we're trying to mimic. And as we heard earlier, it's challenging with the insulins that we have available to mimic the natural secretion of insulin. Well, and the other thing I like to point out about this diagram that's hard to see, but actually the insulin starts to rise just a little bit before the blood sugar rises. So native insulin actually begins to secrete before your blood sugar starts to elevate just a little bit. And so we are trying to mimic this pattern, and it is can be quite challenging. So there's multiple ways to give insulin. We heard about subcutaneous injection with a lot of detail. What I'm going to talk about is continuous subcutaneous insulin infusion. In the old days, we even called it we call it CSI, but anyway, it is now, this is done when people have an insulin pump. That's what it's doing. And there's a couple of different ways that you can do this. There are standard insulin pumps, and then there's what's called partial closed loop, and then there's true closed loop. And I will get into more detail what these things mean. So partial closed loop is when we say partial closed loop, these are the newest types of pumps that are out and available. And that's when the pump and sensor talk to each other. So a standard insulin pump that was available prior to these partial closed loop systems couldn't do anything on its own. It gave you insulin through a continuous infusion, and but if you wanted it to give you any particular amount of insulin, you had to tell it. So you had to set how much insulin you wanted to give you at a different time of day. And then anytime you were high or low or whatever, you would have to change the amount of insulin it was giving. And you would have to do that very intentionally. And even if you had a sensor that sent the information so it read out on the pump didn't do anything with that number. So when we're talking about partial closed loop, we're talking about a system where the pump actually does something with the information that the sensor sends. And these systems will automatically stop insulin for lows or reduce insulin when you're dropping too fast. And some of these systems will give insulin for highs or if your blood sugar is rising too fast. Partial closed loop systems do not handle meals well. You need a very different dose of insulin if you're getting high because you ate versus just a high happening because of stress or because the previous dose of insulin wasn't quite right. And the partial closed loop systems are set up with the thought process that you're not eating. And so if you don't count your carbs right, the system will not give you enough insulin. And most of these systems are set up in such a way that if the system can't figure out what's happening, it will kick you out and stop running. And then you lose the benefit of the system. So for a partial closed loop system to work properly, you absolutely have to count your carbs, and you really need to count them accurately for the system to give you a good A1C. Also, most of these systems do not handle exercise well, especially people who exercise a lot, such as like elite athletes. So when I have an elite high school athlete or a collegiate athlete who's on one of these systems, they often really struggle having the system deal appropriately with the degree of exercise they have. Most of these systems require you to tell them when they're exercising, and they do and need a fair amount of adjusting, because when you're exercising, of course, you use up glucose faster. And so a lot of the systems will kick you out because your blood sugar is changing in a way that doesn't make sense to the system. The systems are set up for safety. So if things are happening that are outside of the system parameters, they default to kicking you back out into what's called manual mode, where they don't do anything on their own and you are 100% in charge of how much insulin you're getting from the device. So let's talk about the different insulin pumps that are some of the different insulin pumps that are available. I'm going to talk about, just because I'm really trying to keep this thing under 20 minutes, much like the sensors, I'm just going to talk about the pumps that I routinely use, and I'm going to do it in the same order. So from more or less, actually Medtronic's my favorite pump, but their sensor is not my favorite sensor. So we're going to start with Medtronic, much like we did with the sensors. The Medtronic pumps are called mini med pumps. These are a pump with tubing. So a pump system, I hope you guys can see my arrow. You have the little site. And so the site is where the insulin goes in your body. This is basically a really tiny, like an IV, when you have an IV put in. So like you have the plastic tubing over the needle, and then you put it in your blood vessel and they pull the needle out and they leave in the plastic tubing. This is a miniature IV cannula. It's a little tiny needle and a little tiny short piece of tubing, and it goes under the skin into that same subcutaneous space that we were talking about with the sensors. And that's where the insulin is being infused into. And so you have the site, and then you have the tube, and the tube goes from the site to the pump, and the pump has a syringe in here that's full of insulin, and it gradually pushes the, whoops, I went too fast. And it gradually pushes the insulin through all that tubing and into your body. And so this is the Medtronic pump, and you can see it shows the blood sugar from the sensor on the top of the pump. And then it has all these different buttons so that you can make adjustments as needed. And then that it also shows all the information you might want to see on your phone. And then also you can see some of it on your watch. And here's the sensor that we discussed before, the Enlight sensor. So the Medtronic was the first company to have an FDA approved partial closed loop. And so that the 670G is the name of the pump that has partial closed loop. And so it auto adjusts for lows and highs. As I mentioned, you have to count carbs, and then you have to calibrate because you're using the Enlight, the older Enlight sensor, which requires calibration. The 780G is a new one. It is about to come out, and it is also a partial closed loop, but it is getting closer to a full closed loop, in that the 780G has the ability to do some compensation if you count your carbs incorrectly or if you forget to count your carbs. Although you really do need to still count your carbs, it has some ability to compensate for that. And that's the only pump available that isn't a full closed loop that can do some compensation for carbs. And that will use the newer version of the Enlight sensor that does not require calibration. And so I don't have anybody on the 780G right now. I do have a couple patients on the 670G. And it is a nice system, except the sensor. This is my personal opinion, okay? I don't get any money from Medtronic. So this is the Omnipod system. This is my patient's favorite system. It is not my favorite system. The real selling point of the Omnipod is that there is no tubing. So the entire pump is in this white thing, and it's all self-contained. So you have to actually inject the insulin into this thing. And then it has a little cannula with a little needle underneath it. Auto inserts the cannula, and the cannula is right under the device. And the device is held on by a giant thing of tape. They never show the tape in the pictures. There's a giant circle of tape around this thing to stick it to your body, and it holds it on your body. And then you use your phone or a device that comes with the Omnipod to tell it to insert the insulin cannula, and then it infuses insulin. There are obviously no buttons on this thing. It is waterproof. You don't have to take it off. I should note that although the sensors typically last for 7 days, pump sites have to be changed every 2 to 3 days. So with a tubed pump, you change just the part that you insert, and you hang on to the rest of the pump. With the Omnipod, you actually get a whole new pod every 2 to 3 days, and put fresh insulin in it. And so the Omnipod comes in the standard version and in the Omnipod 5, which is a partial closed loop. So the standard version has just the manual. You set everything up, you tell it what to do. And then the Omnipod 5 is that partial closed loop, and that's a pump talking to the Dexcom G6. And you have to count carbs, but you don't have to calibrate. And that's because you use the Dexcom sensor. And it looks the standard Omnipod and the Omnipod 5 look very similar as far as what they look like on the outside, but the guts are really different. And the Omnipod 5 includes they use the artificial intelligence algorithms to predict where your blood sugar is going to decide how much insulin to give you. That's how these systems work. All right. So my favorite pump is actually the t:slim, but not my patient's favorite pump. So the t:slim is also a tubed pump. It also talks to Dexcom G6. You can set it to just be a regular pump. You can set it to be to just correct for lows but not highs, or you can put it on a full partial closed loop where it corrects for both lows and highs. It does not have any ability to deal with food. You have to count all your carbs. You don't have to calibrate it because it talks to the G6. t:slim currently has 2 models. They have they actually are pretty much exactly the same. The only difference really is the size, and the Mobi does not have any buttons on it. So if your phone dies, you can't control the Mobi. Also, it only talks to an iPhone at the moment. The t:slim X2 has the touch screen capable. The cool thing about the t:slims is that they are able to have push updates for software. You don't have to get a new pump to get new software, which is one of the things I like. The Mobi is so new that although it's theoretically available, I don't have any patients actually using it right now. And then you can see the size of these devices. And the Mobi is quite a bit smaller than the Medtronic pump or the previous t:slim pump. And I'm not sure if it's smaller than the Omnipod. It's very close in size. Looking at the pictures, I've not held a Mobi, so I'm not sure, but it's probably pretty close in size to the Omnipod. That's about how the Omnipod is, about that size. So that is the t:slim pump. And so the last thing that we have is what's called a closed loop. And a closed loop means that you don't need the human involved in order to have decent blood sugar. So this is often termed a bionic pancreas, which means it's a device that you wear externally that can mimic as best as possible a pancreas with minimal assistance from the patient. So the iLet bionic pancreas is the only closed loop system that is FDA approved. This has tubing. You can see this looks, the part that you wear or the infusion site where that has like the tiny sort of kind of like an IV cannula is very similar to what you see on the other tubed pumps. And that has the tubing that goes to the pump, and the pump has a little insulin in there. And the thing about this thing is you can see there's not a lot of buttons on here. So it shows you your blood sugar, and then it shows you the system's running, and then you can tell it you want to eat, but you don't have to count your carbs. You just tell it you're going to eat. And if it's a usual size meal for that time of day, a large size meal, or a small size meal, and you don't set any of the insulin levels in this device, you tell it your weight and you turn it on, you put on your sensor, you put on the site, and it goes. And it currently utilizes the Dexcom G6. And this device, really, you should be able to just wear it and the sensor and tell it when you're eating, and it should be able to handle your blood sugar. And obviously you can see what your blood sugars are, but you really don't do much with this system. It's almost complete. It's basically nearly completely autonomous and doesn't require a lot of user interaction. So this is a pretty neat device. I haven't prescribed this to anybody yet, so I've only seen this used in the context of studies, but the data from the studies look really nice. So we're very excited about the future. And all of the companies that make these devices are working towards this sort of closed loop, where The idea is to really remove the burden of diabetes from people with diabetes, because for any of you who have diabetes know, we tend to think if we don't have diabetes that it's the pokes. That's the hard part. But the really hard part for most people with diabetes is just the amount of interference that it gives to your daily life and the amount of work you have to do to maintain your blood sugars and goal range. And so the idea of this type of device is that you can really reduce the effort. And I will say, in the years that I have been a diabetes doctor, the invention of the continuous glucose monitor is the first thing that has happened in my career where you could actually get better control of your diabetes with less effort. Everything else that I've experienced in my career, no matter how miraculous, you had to put more effort to have diabetes control. You could get better control with the new technology or what insulin or whatever we were using, but it was always more work to get better control. And these new devices are actually the first time we're seeing improved control in people without them having to put in a huge amount of additional effort to improve their control. So it's very exciting. So the bad part of the story is getting these things, and this is specific. The rest of this talk, I didn't really have any specifics for pancreatitis-associated diabetes or type 3C diabetes. And unfortunately, the really relevant part is not so great, and that is insurance coverage. So all of these devices are FDA approved for type 1 diabetes. Some of these devices are FDA approved for type 2. So what this ends up meaning is that it can still be challenging, but most of the time we can get these things paid for people with type 1. Sometimes we can get these things paid for people with type 2 and other types of diabetes, such as type 3C. So, but it's definitely not as good as the coverage for type 1. And for the most part, these devices are quite expensive, and the monthly cost for all of the different pieces of equipment you need to make these run ends up being very pricey. And so they're not accessible except maybe the Freestyle by itself without a pump, without insurance coverage, unless you're very wealthy. And so lack of insurance coverage tends to equal lack of access for people. I have been pretty successful being able to get Dexcom and Freestyle covered for some of my patients with pancreatitis. Of course, I'm working with pediatric patients, so I don't know how well these are covered for adults, but it's been reasonable, but I would say it's definitely harder to get covered than it is for somebody with type 1, and I don't always get these things when I want them, unfortunately. So that's all I put together, because I was trying to say within 20 minutes. I don't know, I actually managed it, but I'm of course happy to take questions. Here's my email if anybody wants to reach out to me. All right, I'm going to stop sharing my slides.
All right, well, thank you very much, Katie, Dr. Larson Ode. That was wonderful. Our last part of this evening before the Q&A is to introduce our patient speaker. That is Derrick Winke. He is actually a chair for the NPF of the Michigan chapter. Just give you his bio, but I'm sure he can tell you his story a little bit better than I can. But he was diagnosed with pancreatitis in 2016, and he lives with chronic pancreatitis, exocrine pancreas insufficiency, and type 3C diabetes. And he is working by day as a tax accountant, financial advisor, and has a growing small business. This is in his words from his bio, he is alive today in part due to the support of his wife, Robin. And he lives in Michigan and has 4 children and 5 grandchildren. So Derrick, I will turn it over to you to share your story. Maybe you can just start off by giving us a little introduction to your pancreatitis and how you were diagnosed with diabetes and your journey there.
Well, my story with pancreatitis started in 2016. It was the genesis for most of the problems that I deal with today. I thought I had a case of the stomach flu for 2 to 3 days. Actually went to work on a Sunday morning at 8 a.m., drove myself home at 9. At 10 o'clock, I couldn't function and had my wife take me to the ER. And I stayed in the hospital for the next 9 months, 3 months in a coma. Since 2016, I've had 56 surgeries, but I'm fully functional and back living a healthy, normal life. One of the observations or things that I learned, which Dr. Pratley brought up, is it's vitally important if you have pancreatitis to work with a doctor that has experience with pancreatitis. All doctors know about it. Very few have hands-on experience with it. I was fortunate with the first hospital that I was in for 5 days. One of the doctors took my wife aside and told her if this went bad, I needed not to be at that hospital. She found a specialist who took me on and, basically saved my life. So find an experienced doctor, contact the NPF, the Centers of Excellence. There's over 50 of them now. It's just a huge factor. That's my backstory. When I first got out of the hospital, after I had my Whipple, most of my pancreas removed, my gallbladder removed, that's when the diabetes, the type 3C diabetes, started. When I first left the hospital, I asked my surgeon what my dietary restrictions were. And I had seen dietitians and have a whole team of doctors. His answer to me was really important. He told me I didn't have any dietary restrictions. He told me, listen to your body will tell you what you can do, shouldn't do, and definitely don't do. So that set me on my journey to educate myself and start collecting a lot of data. Back then, I started out with a detailed food log. I put everything that I ate into a program called MyFitnessPal. I coupled that initially with my glucose readings. Back then it was poking my finger. Now it's with a CGM. And I just learned what I can eat and what I can't eat. And I recommend to everybody that's dealing with diabetes, especially type 3C diabetes, got to have a continuous glucose monitor, because your body will tell you what you can eat. I even know what my medications do to my glucose. Because of EPI, I take Creon, which is not good for a diabetic. So the other thing that I learned was the importance of having a patient advocate. Normally that would be you, but when things go bad, maybe it's a spouse, maybe it's a parent, maybe it's another family member. Along those lines, I developed what I call as a patient passport, where I've condensed my medical history. It's now 3 pages I update that every 3 months because that's how often I get my blood work done. And I carry 3 copies with me. One is for me, one I hand to the nurse, one I hand to the doctor. My surgeons have advised me that they could do surgery based on what I've got on these 3 pieces of paper. Going through this exercise really allowed me to educate myself as to what's going on. I've developed my own protocols for when my certain blood tests come back and I start to become symptomatic. I know which doctor I need to call. So I can't emphasize enough the importance of you have to be your own quarterback. You've got to be in charge of your health. You don't have to become a doctor. Some of the residents tell me I'm close, but ask lots of questions. If you're not getting the answers that you like or understand, go find another doctor, go find another medical professional. Can I share my screen?
Yes, we might need Katie to pass off host privileges.
I already did,
Oh,
but
perfect. So you should be able to, Derrick.
Oh, share screen. So this is my medical passport, which I have PDF versions and blank Excel versions if people are interested. Basically, I've got all my conditions, most of the procedures that I have, the drugs that I take, my allergies, my vaccinations. I track my antibiotics because that can be a thing. I have my ongoing issues. On the next page, I take a ton of vitamins. I have my team of doctors. I track my hospitalizations, other tests. I have a pain profile for what drugs work for me, what drugs don't work for me. I keep track of my last 2 blood draws and pay attention to things that, are important or not. Last year, I moved up to a 3rd page for drugs that I'm no longer taking, why I'm not taking them, vitamins that I've stopped, and other things. And then I have a blank one if, somebody is interested in, going down this road to, help track their conditions.
Yeah, that's wonderful, Derrick. Thank you for sharing that information and that template. I agree that it's very helpful when a patient comes in from a physician's perspective too, and has a concise history to bring with them.
Yeah, my observations were I usually end up at my primary hospital. Yes, the doctor has access to 1,000 pages of my medical records, but I've only got the doctor maybe for 10 or 15 minutes. So how can I use his time to get best care?
Well, I think if it's okay with you, we can open up for questions because I see there are a few in the chat or the Q&A for you, Derrick. Maybe I'll just start with your kind of history because there's a couple of questions about the Whipple. How was it that it came to having a Whipple for you as the choice of surgery? And if other individuals who are on this call want to reach out to you with questions, is that okay to reach out to you?
Yes, we're perfectly fine. I've got all sorts of responses for a wide variety of questions they might have. In my case, I had necrotizing pancreatitis and I went septic. So that just started the journey of a lot of surgeries, and I lost probably about 40–45% of my pancreas. So when they had to remove that, that's what necessitated the Whipple surgery.
Okay. Yeah. And I think if people want to reach out to you, maybe they can reach out through Sockfall and get your contact information, your email.
Yes, that's fine.
Perfect. And then there's a question you were kind of getting at, how you figured out that certain foods worked for you and didn't. But one of the attendees was asking what foods do seem to work for you in your diabetes, and how do you figure out and balance everything with multiple chronic illnesses?
Currently, I am on a modified ketovore diet. I did read several books on a keto type diet. I practiced a modified one because I'm a diabetic. I can't just fast for like a whole day. I do need to eat something. And just following my food log. If I have spaghetti, too much pasta, too much carbs, not good for me. I can have a steak, I can have turkey, I can have chicken, I can have pork. Try to choose the lower fat meats, but that just doesn't really negatively affect my diabetes.
Yeah. And I think, Derrick, you said something as you were going along that I think is very important. And I actually think this for all forms of diabetes, and I'm sure the same for pancreatitis. But people are kind of their own experts on their own diabetes, right? Everyone's a little bit different. And we as physicians know the sort of general treatments and their, mechanisms and their impact, but everyone has their own diabetes journey and the way their body reacts.
I never argue with somebody who's had diabetes for 50 years. They are clearly the expert.
They're the experts. They live the disease.
Yeah, just with technology, I'm kind of a techie person. With CGM and a food log, you can really narrow it down. At one point, I stopped taking a multivitamin because I went through 6 different multivitamins and I couldn't find one that wasn't negative on my glucose. So now I take 20 different subvitamins.
Yeah. Maybe I'll give you a little break here, and we have a question. Maybe Rich, Dr. Pratley, I can throw this to you, although I'm not sure that we'll have an answer for this. I just don't know if we have the data. But there's a question here about pancreatic atrophy, I presume from chronic pancreatitis and type 3C diabetes. And does this affect heart health? And do we need to be concerned about that? Oh, you're on mute, Rich.
It's a really great question, and one I don't think we have a really great answer for, unfortunately. The problem is that by and large, we haven't diagnosed type 3C diabetes very accurately, as I pointed out. And we don't know what the natural history is in terms of complications. In some sense, living long enough to develop cardiovascular disease is a good thing, because it means you've made it through all of the acute complications associated with acute pancreatitis or chronic pancreatitis, and that you're, in a sense, managing that part of things well. But we do know that with all the types of diabetes that we know about, including gestational diabetes, there's an increased risk for cardiovascular disease. We don't exactly know why that's the case, but I presume that this is also the case with type 3C pancreatitis, in part because many of the risk factors for type 3C pancreatitis overlap with those of generally type 2 diabetes. So I think we have to assume that there is an increased risk, and because of that, treat diabetes well, but also pay attention to all of the other risk factors for cardiovascular disease. So clearly, good lipid control, blood pressure control. Where it gets sticky is using medications for diabetes that are shown to have a cardiovascular benefit, like a GLP-1 receptor agonist. That's where we have zero information, and we could really use some better information, because while these drugs are great for reducing risk for cardiovascular disease and renal disease, there may be an increased risk for recurrent pancreatitis that we don't want to assume.
Could I add in?
Please.
So there really isn't enough data, just like you said, in pancreatitis. We do have emerging data in cystic fibrosis related diabetes, which is probably the closest related form of diabetes to type 3C as far as the data we have available. And we used to think that the fat malabsorption was protective against cardiovascular disease, and that does not seem to be the case now that we have people who have, as was just mentioned, longer standing lifespans. We're seeing cardiovascular disease. So I think it's a safe assumption that anybody with diabetes should be being really careful with their heart health. I always tell my kids with type 1, if we're doing this right, people with diabetes die of their heart disease. And so everybody with diabetes should be really paying attention to things that we know modify heart disease: getting exercise, eating healthy, which we've heard some very good talks about how to do that already. But that's really probably something we should assume. I would say that your pancreatic atrophy, to address the patient's specific question, I don't think that's going to be any particular higher risk with that exact phenotype. I think more it's just the presence of the diabetes, and pancreatic atrophy is probably going to indicate you're more likely to have diabetes. So I would say that would be my thought process, would just be, what is your, do you have diabetes, and how well controlled is your diabetes? I would like to throw a little thing out there about ketogenic diet and diabetes. I've actually managed people on ketogenic diets, or not directly, but we've had people in our practice who've been on ketogenic diets for seizures, because the only scientifically validated use of a ketogenic diet is to treat seizures in kids. And went on a full ketogenic diet, but people on long-term ketogenic diets have advanced and rapidly progressive atherosclerosis. So you have to be careful with being ketotic, not just because of the diabetes, but because those are fat pieces. So the ultra low carb diet, which I think is what Derrick is probably actually doing, does have a little bit of data and probably is really helpful for diabetes control. But as he said, you need to be careful to manage your fat. And a lot of the ketogenic diet stuff floating around in the kind of influencer verse, you have to be careful if that's actually healthy, or if they're just trying to lose weight. Now, Derrick's plan, I think, is working. And of course, as you mentioned, everybody knows their body best. And if you're doing stuff that's looking good on your CGM, it's probably working. So, but that would be my thought on cardiovascular disease. But we really don't have enough data, unfortunately. So sorry about my itchy eyeballs.
All right, the next question, and it's regarding like type 3 diabetes, but probably any of the panelists can answer. So it says, for a parent that is just starting this type 3 diabetes journey with their child, what is the best advice that you can give them to help their daughter to be her own advocate?
Well, I'm always willing to talk. My first question for that would be to ask you how old your daughter is, because the thing about, I assume this is not an adult person. The thing about a non-adult person, a kid, is, well, how well they can self-advocate is really dependent on their age. And I would say for my pediatric patients, even my teens, they really need their parent to be an advocate. Much like Derrick said, you really need that support person to be there for you when you have complex disease. We should just make you answer all the questions, Derrick.
It says that,
but and especially for
the child is 9.
Did she answer?
Yes.
Is 9, yeah. So in that particular scenario, you're her advocate. She's not going to advocate for herself adequately at age 9. But if she has she should be it's a good sign. And when Derrick was talking about how to find a good doctor, not only do you want somebody who has expertise in pancreatitis, you also want somebody who's going to talk directly to her, answer her questions directly, and address the things that make her worried. And that so you should have, if you have a appropriate pediatric doctor, they should be talking to both the child and to the parent, but you are her advocate, especially at that age. But even if she was 17 years old, my 17-year-olds still need their parents really, really on their team. Even though they will tell their parents they don't want them on their team, they really need them. So the best advocate for a kid is their parent. And I would not ever expect one of my kids to self-advocate because it's so complex. But yeah,
I was going to just chime in and say that by serving as their advocate, you're also modeling the behavior that's going to serve them well as they mature, as they grow up, and as they take more responsibility for their own chronic disease. So I think that's a very important function. And parents have sort of different ways of dealing with doctors. And so being proactive, asking questions in front of the kids, asking the kids how they're doing, are all important parts of that behavior modeling that are going to help them be effective advocates.
Right, and from a patient perspective and a parent, include your kid, even if they're young, include them in the advocacy process as it's appropriate. It helps educate the kids also.
Yeah, but I think Dr. Pratley, acting as a role model is so important, and how you cope and react with things and still, make the best functional life for your kid and be her advocate. I know we're over time here, so I apologize that we haven't gotten to everything. There are a couple of questions about Creon in here, so I just wanted to wrap up with this question about Creon, because Derrick, you had alluded to Creon and diabetes, and I'm curious on your thoughts. I think what you were probably alluding to is that if you're taking your Creon, you're actually absorbing things, and you're getting more blood sugar spike associated with that. Probably not because the Creon has a direct blood sugar effect, but the absorption. But what were your observations with the Creon?
Correct. Medically, it may not be the cause, but I just know when I take Creon, it does make glucose management
More difficult.
a little bit more difficult.
Yeah, so it's really interesting, and that's a part we didn't really touch on, but as endocrinologists who are familiar with pancreatitis, when we see patients in clinic, we really assess that Creon use too, because if someone's very variable about Creon and takes it sometimes and not other times, they also get variable absorption and may have different responses. So that was a really astute observation, I think. But maybe if people still have questions in here that we haven't gotten to, and they can just perhaps send out an email. Oh, Katie wants to add to that.
Dr. Bellin, can I just say something about Creon? So I don't think that this is going to help Derrick much because he doesn't have a pancreas, but for my patients where they still have some function, I actually think enzymes support the pancreas and support the endocrine function. We're actually trying to put together a randomized control trial to see if we can actually use enzymes to prevent development of diabetes. So and I personally, of course, this has been proven, but I really do think that supporting the exocrine function supports the endocrine function. So I would really strongly encourage you not to avoid your Creon. As a doctor who does this, please.
And I think Dr. Pratley had his little diagram, right, of all the mechanisms. And one of them are these hormones that come from your gut called incretins. And there is some evidence that when people have exocrine insufficiency and they take their Creon, that communication from the gut to the islets actually works better. When they have there.
We also have a little bit of data from CF that function of your exocrine pancreas has hormones that come directly from the exocrine pancreas to the endocrine pancreas. So any residual function of the exocrine pancreas can support the function of the islets. So, so that would just be, I'm somebody who might actually live for the pathophysiology of exocrine pancreas and endocrine pancreas interaction. So this is like my favorite thing. But so anything that supports the function of the exocrine pancreas, which not everybody has anymore, but if you have any exocrine pancreas tissue left, it can support the endocrine pancreas. So that would be my thought on Creon.
All right. Well, thank you, everyone. I think Sakfal, I apologize I didn't get to everyone's questions, but I think since we're 20 minutes over, if people have follow-up questions yet, maybe they can reach out to the NPF and we'll be happy to pass those on to the relevant speakers who might be able to answer them.
Yes, exactly. Thank you, everyone.
All right. Thank you. Thank you to our speakers, especially for taking extra time tonight. And Derrick, especially thank you for coming and being so willing to share your story. And we're anticipating probably a third in this series of diabetes webinars, although I must admit we're not quite sure what the topic is yet. So if you have things that you'd like to learn more about, please feel free to let us know that as well. And we will hopefully see you at the next one in a few months. Thank you and good night, everyone.
Good night. Thank you.
Good night, all.
Good night.